Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining me. I'm very pleased to have James Roxburgh with me here today. James is a telehealth expert and the founder of Virtual Care Services. Welcome to the show, James.
Thank you, Tim. Nice to be here.
All right, for our listeners and viewers, why don't you please give us a background on the state of telehealth and what Virtual Care Services entails?
Well, I sure will. And again, it's an honor to be with you. Thank you for your time. Well, telehealth is really took off a couple of years ago when COVID hit. And prior to that, I used to say it was kind of a gimmick. And it was being used for services such as stroke care, acute stroke care, critical care, some behavioral health. But when COVID hit, suddenly the whole environment changed and we had to come up with a solution. So guys like me who were sort of on the, not on the main stream of things in terms of healthcare and doing telehealth, suddenly we were put to the forefront. Okay. And so my company, Virtual Care Services, is an advisory company. We work with hospitals, healthcare systems, physicians, physician group practices to help them implement, support, scale their service in a financially responsible way.
Okay. Can you talk a little bit about what happened for you in COVID? What the baseline for use was, and where it is now, and how that transitioned?
Yeah, I'll go back a little bit in time. My healthcare background is actually about 5 decades now. I've got a clinical background, administrative background. And I've been involved in virtual care or telehealth or telemedicine for about 15 years. Originally, that was I was brought on to develop a stroke network for Dignity Health in Northern California. And so that was the, and you can really do good stroke assessment using audiovisual tool and the different digital tools that go along with it. When COVID hit, there was a mass confusion because physicians and providers and nurses and ancillary staff were having to gown up to go in to see the patient. So hospital systems were trying to figure out how can we avoid having to go into the room so often. Sure. and all of the expense and the time and effort and so forth. So I've always had this idea, and I went for it when I was the CEO of Tele-Health at Banner. And what we did was we converted television sets into what we call endpoints. So we basically using as we use a little computer, we attached it to the television set. We had a camera and a speaker microphone, and we made these little kits. We attached them to the television sets. And now the physicians could connect in virtually and do their assessment with the patient. Right. And so I can go into that in more detail, but that was a major breakthrough in terms of providing care. And we were able to add in interpretive services and bring in family members and so forth. So and actually now there's probably about 6 companies that make these kits that convert television sets to virtual endpoints.
Okay. And so it wasn't really remote access; it was in-house stuff. So just for general rounds, even they can see people without having to expose each other.
Yeah, good question. We did it 2 ways. We would have the physician; they could be at a control station out at the nursing station and see the patient virtually. And the nurse would actually not have to go into the room except for a couple times during a shift, but they could stay at the edge of the doorway without having to gown up. So we did it internally, and then we would do it across campus. So you could have one internal medicine or hospitalist doctor cover a couple hospitals. And that saved a lot of time. It saved a lot of the PPE expense, and it improved the access to care, which was utmost important.
Sure. What were some of the bigger challenges for you at that time in growing the telehealth in general?
Setting it up as fast as possible. We don't know. We did about 1,200 rooms in a few months, and that required biomedical team who were fabulous, IT team who was fabulous, to go in and set up these kits in the patient's room. And you can imagine the effort it took to do that while the patients were we were dealing with COVID. It was tremendous, but that was a major effort, practically around the clock, to get it set up. That was the biggest challenge we faced.
Okay. Do you know Alan Pitt? He's a physician I had on. He was co-founder, I think, of Vital Chat.
Vital Chat, you're a good friend of mine. Yes.
Okay.
Yes.
Excellent.
Yeah.
So is that sort of similar technology?
Yes. Alan and I go way back. He's a brilliant man, and he started the company Vital Chat, and they use a technology where they developed a kit that converts the television set to enable that audio-visual connection. Yep.
Okay. Excellent. Okay, and how has it grown? Do you have numbers for over the past 5 years? How this is launched? I get stuff from my insurance provider and stuff. It's a service they provide for free, right? They're trying to save costs and get things dealt with as more cost effectively as possible.
Yeah. I don't have specific numbers in terms of how it's grown, but I can tell you that post-COVID, there was a dip in telemedicine. And if you look at Teladoc stock and Amwell stock, you can see that it's gone down. And that's primarily because we were so intense in doing everything virtually. And then there was a kind of a step back and sort of a readjustment, which is a natural progression. But I can tell you that the need is growing tremendously, because not only in the hospital, but in the home, and in assisted living facilities. This is a burden of mine, independent living. And so the number of people turning 65 each year is growing. I think 1 in 5 people in this country in about 5 years are going to be over 65. So as an example, there could be somebody down the street from you that has poor access to care, and they're living in a very nice urban area. Well, we always think of the rural areas that don't have access to care, but there's a growing number of people that are not being treated because of the limited access or their ability to gain access. Behavioral health, general care, and so forth are just a few of the examples.
Okay. Yes, good point. Before we move on, let's talk a little bit, if you can, about maybe some of the misconceptions that people think telehealth is and what it is and what it isn't.
Yeah, when I started in this business, there was a lot of physicians who were very skeptical because they were used to touching the patient, feeling the patient. But we live
and that can be important, right? People who are
very important.
Yeah, you need to be around live beings.
Yes, and I'll tell you that it can be handled properly. But with all the digital tools we have, if you go into a hospital now and watch a lot of physicians, very, very rarely are they really touching the patient. They're looking at the scans, the images, the lab bags, and so forth. They have
They're charting at the computer with their back to you.
Charting at the computer, which is a big distraction.
Right.
But there's a phrase that I've coined, and I call it decision support. And here's what I mean. If you have a specialist connecting virtually to see a patient, and you have somebody at the bedside, such as a nurse, an ancillary personnel, or a local physician that may not have that expertise, they can help the virtual doctor through decision support. Right. So the doctor can say, I need you to touch this, do this, and then they can support that doctor. So you can actually do a lot without having the specialist in person.
sort of a hybrid approach, combination
That's right.
of
That's
teams.
right. Yes.
So, what are the who are some of the bigger clients, I guess? How are virtual care services is coordinating with different groups, different people? What sort of is there like a hospital who's trying to implement something, they need help? Is that when they reach out to you, or how does that work?
Yeah, it can be a health system, hospital, physician practices, individual
Individual
physician
practices?
practices.
Okay.
And I'll go down that path a little bit. Now there are Medicare codes for remote patient monitoring, chronic
Mm-hmm.
care management, RTM. These are remote therapeutic monitoring. And this is where a patient is at home and they're taking their blood pressure, or they have a wearable device like I've got. This
Mm-hmm.
will measure my blood pressure on a regular basis. And this ring will measure my blood pressure continuously. And I can do an overnight sleep study very easily. So with these devices, now I help support physicians to set up a practice where they can take care of the patient and then do it in a financially, responsible way. So, and then I continue to advise healthcare systems. I finished a gig with the Saudi Ministry of Health and the National Guard for their telecritical care and telestroke program just this last summer, and telehome
Nice.
program. Even though the technology is out there, the workflows and the operations to develop it and support it are still not that sophisticated. We still have a ways to go.
Okay. So what advice would you have for one of those places we just mentioned who
Yeah.
needs to improve their systems?
Yeah, I look at it sort of in three buckets. The first one is the technology. And one of the problems systems get into, or providers, is they see the next shiny thing and they think this technology is going to do it. That won't cut it. You need to define the clinical workflow first. What are you trying to achieve? Once
All right,
you do that, you know what I'm talking about. Then
yeah. Oh, yeah. That's a wise answer. I can tell already. You've been through this.
Yes. When I started in this business, a lot of programs were founded off of grants, where they would write a
Yep.
great grant proposal, get a lot of money, buy the technology,
Buy the toys and
buy the toys, and it would sit. So I've always approached it working from the bedside back and from the provider, the user interface towards the patient. And if you can create that connection, that successful connection in an easy manner, then typically you can have success.
Okay. Sounds like probably one of the bigger challenges it's probably to overcome is the implementation of this process and technology.
Yeah, I'm glad you mentioned that because I'm going to tell you a long story short. When I started, this is with Dignity, I had this big whiteboard in my office of all the implementations and the process we were going through. And I was driving home one night and I Googled, I shouldn't have done it while I was driving, but I Googled dynamic spreadsheet. And I came across the ability to, now it's second nature, but have a spreadsheet in the cloud.
Right.
So that we would organize the implementation for the partner sites, the hospitals or physician practices. We would organize it where who's responsible for what and how you're going to get it done. Very basic process, but typically in implementations, you don't see that. So number one lesson, define the workflow. Number two, match the technology to it. Number three, lay out a very detailed implementation plan and then follow through with that. And typically you will have success.
Okay. Excellent. Let's talk about maybe some of the goals for the company right now. Bigger goals, maybe you have something in the short term and the longer term horizon goals.
Yeah, I am very interested, as I mentioned earlier, in supporting the aged population.
Okay.
And there's a phrase, I didn't coin it, called age in place. And one of the most important things as we age is to maintain our independence. And part of my background, I did home health care in the past. And when people can't manage their medications, when they can't manage their appointments, then they say, what do? We got to send them to a skilled nursing facility or
Right.
assisted living. So I have a goal, and this is one of the things my company is working on, is how can we support patients to maintain their independence in their home? And even if they have to go to an independent living facility, let's support them there, even assisted living and so forth. And we can do that without having them to go back and forth to the hospital or to the ED, because that's not financially smart and it's not good for the patient. We can do that, I believe, with using remote monitoring devices and virtual support to the patient, as long as it's done in a seamless and a simple way.
Right. And I'd go be so bold as to say better care, because it can get more continuous data and get alerted to issues as they come up quicker.
You bet. And I'm also glad you mentioned that, because typically healthcare is done to us. And I want the client or patient to be more engaged in healthcare, have their own medical record, have their own, vital sign monitoring and so forth. So they're in control. And I think when we allow that, then there's less reaction, because the reaction a lot of times is a trip to the ED. Where something is maybe trending downward or upward, depending on the physiologic parameter, and there can be an intervention done at home and avoid the intervention in the ED.
Right. Get at it before it turns into a bigger problem.
Yeah.
Okay, excellent stuff. I'm excited for all of this, James. What are some of the biggest hurdles to those current goals?
The finances and managing through the finances is always a challenge. And I always say in healthcare, follow the money.
Yep.
And a lot of times innovative type things are a little behind the reimbursement. So I've always been one, and you know that, and I've always been one with telehealth to sort of step out a little bit and prove it, and then and sort of back in, to the solution. And I'll give you an example of that. When I set up in a rural hospital in Northern California, their tele-ICU, we call in the States, program, I didn't have any data to go on, but they had a 6-bed ICU, and typically they would transfer the patient that were critical, because they didn't have the intensivist to support. Yeah, they didn't have the intensivist to support them.
Okay.
So I worked with the administrators and I said, let's look at all of your top 20 DRGs, your diagnosis, and let's see if you kept this patient, this diagnosis, what would it pay? What was the cost?
The insurance reimbursement, right?
That's right. If you kept this one, what would it pay? If you kept this one. So we did some speculation and we said, yeah, we could probably keep these 3 patients. Well, that would pay for the cost of the telehealth equipment and the provider services. So we sort of back-ended it that way and had them see, yeah, this makes sense. That became a very successful tele-ICU program because they kept their patients. Not only did they keep the patients in the community, the nurses got more training because they got to see the patients. The family didn't have to traverse 60 miles to go see their loved one. And it keeps the economics, as you being a finance person, it keeps the economics in the community, and it's good for those rural hospitals.
Right. And ultimately, the stuff is not all the care providers, everybody working together is a lot of time and energy and cost, and that everyone to keep operating and to do good has to be able to justify all that. So that's a very good point.
And think about this, Tim. I've said before. Imagine you could have a LeBron James playing in 10 cities, practically all at once. I can have a specialist connect within minutes to 10, 20, 30 hospitals and provide that expert care. Get in, get out, go to the next one. Right. And so the economics is there. And the most important thing, the care at the right time is there. And that's one of the beauties. It's one of the magical things that I've seen in telehealth.
So was getting those reimbursement code approvals, or how that must be a whole challenge in itself.
Yeah, I approached it, and it depends on if you're talking about in rural setting or community or tertiary centers. But I'll just give you a sort of a simple example. Those patients that I was talking about at that rural hospital, if they paid for the provider consult, they paid for the technology, they would keep 5 additional patients a week there that they could manage locally, which mean on their cost report, on their charge capture, they were capturing that income that normally would have been shipped out. So that's the approach that I took. But government funding is there, facility fees and so forth. But I kind of approached it from that sort of the back end of, what were they keeping and making versus are we going to get reimbursed for this provider providing this consult? And in my experience, that's kind of slow because you're waiting for the provider to get paid and the reimbursement sort of takes time. I would charge the hospital the fee. They would pay to me or to the organization I was working for, but meanwhile, the hospital would win because they were keeping that patient. So that was typically
Right.
my approach.
Okay. James, this stuff's incredibly impactful, right? This helps so many people as it grows. Um, I'm just very excited about it. Thank you for sharing all of it.
Yeah.
Do you have any, as we start wrapping things up here, do you have any particular initiatives that you're wrapping up for the rest of the year through 2025? Any goals?
Yeah, my goal is to work, I say, with the elderly assisted living facilities is one of my primary goals to enable telehealth type visits there so they can more efficiently take care of their patient, keep them, engage their family members in what's going on through a multi-presence visit, and incorporate devices such as this so that you can have the data so that they can be monitored and triaged appropriately. That's really my focus for the rest of this year.
Okay, excellent. And I mean, I know a lot of people try to do that already and they have their phone live and stuff, but it'd just be nice if it was easy
Yeah.
and already set up and even
Yeah.
documented, right? For them so they could watch it after the fact even.
When you say easy, you hit the nail on the head, Kim. It's got to be simple, and it's got to work, and that's where the operations come in to make sure that everything's done timely. I've often said that we're in a situation like we were with the PC business of the 70s and early 80s, where everybody's trying it. It's a very exciting time, and there's a lot of failures because they don't know how to do it right.
Right.
And critical, I mentioned technology, workflow, and operations. The third bucket in that is operations, which means support, implementation, and so forth.
Okay, excellent. As we wrap things up here again, a reflection question for you, James. What do you wish you knew sooner along your journey?
To relax.
Okay.
I came up with sort of and it hit me. This is when I was working in the hospital, and it was a very intense time. It's sort of a mantra, and this is what I learned sort of during that intense time: be sincere, do the right thing, follow through, and then smile. And I found, Tim, if I follow that, and if folks follow that, it works. And people will respond to that, your team will respond to that, and you can work towards success. So that's probably my advice to those listening.
All right, good stuff. Thanks, James.
Yeah.
Obviously, it helps if you're competent.
Yeah.
But that kind of goes, you already had that one dialed in.
That's the foundation.
Right. Okay. So, James, if people wanted to connect with you, learn more about virtual care services, where can they go? What can they do?
They can go to virtualcareservices.org, and they can easily connect with me. They can see what we do and reach out to me from there. Is probably the easiest way. Or they can email me, james@vcscom.org. vcscom.org.
All right, that's great. All right. Thank you, everyone, for listening and watching. Thank you very much, James Roxburgh, for joining me today. This has been great. I appreciate you sharing your story and insights and letting all of us learn a little bit more about telehealth. Thank you.
Thank you, Tim. It's been a pleasure.
Inspired by our guests? Visit phoenixprosperitypodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.